The Clyde trial was an interesting study. It was performed over a decade ago, and we are now looking at that data again because the drug got approved last year in 2019. So what is interesting is that the study was designed as a relapsing remitting trial. It was not designed as a secondary progressive trial. But in clinical trials these days, you can actually come up with surrogate markers that could be used as markers of secondary progressive patients. And that could include a certain level of EDSS. So you can say maybe an EDS greater than 3 or 3.5 with a functional score of at least 2 on the pyramidal. Or you could use an EDSS score of 6, which requires somebody to use a cane. So those are defined metrics that you could actually use to make the determination, is the patient in the trial hitting those milestones? So as part of the design of the study, patients are followed by their EDSS scores, and if they were at a less than 3, you'd have a baseline score, and then you could measure them over time, and if they increase their disability progression, you could say they hit a milestone of greater than 3.5, confirmed for greater than 3 or 6 months, they would have met that disability progression. And you could have people who are greater than an EDSS of 4 who might progress up to an EDSS of 6, and you can actually look at these metrics and use those as proxies for secondary progressive disease. And in the trial, they looked at this, and they actually found about a 50% reduction of the patients who were treated with oral cladribine compared to the placebo group in those metrics of going by these proxies to hit this secondary progressive endpoint. So I think overall it gives us comfort to say that a medication like this can reduce the risk to go on to develop secondary progressive disease. And in the real world, you're going to ask the question, if I put my patient on this medication, am I going to be able to prevent them from hitting the secondary progressive proxy endpoints that we just talked about? And the reality is, yeah, you might actually have this as a very comfortable place to think, I have somebody who's maybe on the edge of that conversation, who's maybe starting to have some ambulatory difficulty, and if I start them on this medication at this point, I might actually have an impact in the long term hitting those secondary progressive metrics. What's interesting about the Clyde trial and how the drug is administered is that it's a very short course of treatment. So you're really doing it for 5 days, and then the next month another 5 days, and the following year you do 5 days, followed the next month with another 5 days, and then you're essentially done with the treatment. So it's short courses of treatment, and you're asking the question, how good and long-term is the benefit? And if you follow these patients, and that's what they did in the extension trial, they looked to see what proportion of patients were relapse-free, how did patients do, and the long term, is it maintained? And what was nice is, at least from the standpoint of looking at the relapse metrics, there was data to suggest that it is maintained over time. And so if you were concerned that somebody was going to have a relapse within the short amount of time, and then the medication may not be very effective at 2, 3, 4 years, this data would suggest that it's maintained throughout the entire period of that extension, so that you can feel comfortable putting your patients on a treatment like this, and it's going to have a durable effect that's going to last for much longer than the duration of the treatment itself.